Good morning, everybody, and welcome. I'm Chris Perrone, Director of Improving Access to Care at the California Healthcare Foundation, and I'm delighted to be kicking off the 2020 annual meeting of the California Telehealth Policy Coalition. What a year it's been, frightening for many, isolating for most of us, and full of unnecessary morbidity and mortality, but also one in which new heroes have emerged, and recent news gives us hope for a brighter future. A year ago, many of us involved in this policy coalition were working hard to explain the benefits of telehealth to lawmakers and to advance policies that made it more accessible, especially to Medi-Cal enrollees, who, though they probably stand the most to gain from telehealth, are among those who have the worst access to it. At this meeting a year ago, coalition members worked on a set of goals for the coming year, addressing coverage and access, data sharing, education, implementation, and monitoring. One of those goals was to foster an improved understanding of telehealth, and another was to generate a sense of enthusiasm and urgency among California health policy leaders around telehealth's role in meeting the health needs of Californians. I think we can confidently say check and check on those goals. COVID-19 is a tragedy and one that sadly is getting worse, but innovation and progress is often most rapid during a time of crisis, and we're seeing that all around us. Thanks to quick action by federal and state policymakers and to healthcare providers throughout the state, many barriers to telehealth fell quickly, and the use of telehealth grew at a pace previously unimaginable. In fact, in a survey of 2,500 Californians released last month from CHCF and NORC, 62% of respondents who received care during the pandemic reported that they received a telehealth visit, including 65% of respondents with incomes below 200% of the federal poverty level. And for the large majority of those with a telehealth visit, their experience was positive. Almost 3/4 of respondents who had a doctor's visit by phone and nearly 2/3 of those who had a video visit reported being equally or more satisfied with telehealth as they were with in-person appointments. Remarkably, levels of satisfaction were highest among respondents with low incomes and people of color. Among people of color, more than 60% said they would likely choose a phone or video visit over an in-person visit whenever possible in the future. The challenges before us are very different this year than they were a year ago. It's now up to us to make the most of this moment to ensure that telehealth is not only here to stay, but that it continues to advance and to benefit all Californians, to ensure that we move from phone to video, that we reach patients who have digital barriers, that we ensure translation services are readily available to patients who need them, and that telehealth becomes a seamless part of how we provide care, available to patients to utilize when and where it improves access to care and health outcomes. These ongoing challenges are one reason that the CHCF board committed $6.5 million over the year to ensure that all Californians do benefit from telehealth. A cornerstone of this investment is the Connected Care Accelerator, with grants to over 50 safety net practices to build and expand their telehealth capacity, and a learning collaborative to support rapid testing of ideas for improvement and dissemination of successful approaches. We are also supporting educational efforts by the California Medical Association and the California Primary Care Association, and an evaluation of the experiences of California Safety Net with telehealth by RAND. The California Healthcare Foundation is proud to support the California Telehealth Policy Coalition, and I know we're all disappointed not to be in person this year. But May and her team at the Center for Connected Health Policy and Timmy and the Blue Path Health team have organized a terrific day for us. I want to thank them and everyone involved in preparing today's meeting. I also want to thank the other sponsors of today's annual meeting: Buchalter, AARP California, HealthNet, Hims and Hers, Alliance for Patient Access. I also want to encourage more of you to support the work of the California Telehealth Policy Coalition. If you find today's annual meeting valuable or you regularly attend the monthly virtual meetings, I encourage you to reach out to May or Timmy to support the coalition or sponsor the 2021 annual meeting. And now I have the pleasure of passing the baton on to Maequon, Executive Director of the Center for Connected Health Policy. I've known and worked with May for many years now, and she was made for this moment. Her knowledge of federal and state telehealth policy has never been in higher demand. She's built effective relationships throughout the state and country, and she stepped up when we've all needed her most. So May, with great appreciation and admiration, I hand this off to you.
Thank you, Chris, for your kind words, and thank you everyone for attending today's webinar. As Chris mentioned, these are trying times, and we've all had to do things a little bit differently, hence the webinar format as opposed to our usual in-person meeting. However, we have put together a program today that I think you'll find very rich and educational, with a lot of work that we hope that you'll be able to help us with. So our objectives for today: we're going to review the coalition's work that we've done in 2020, and there's been a lot of it. We're also going to provide an update on legislative and regulatory developments, both in California and on the federal level. And we're going to allow some of the members to share their priorities for telehealth policy, advocacy, and action for 2021. Finally, we will finalize the coalition's priorities for the following year. Next slide, please. This is our agenda today. As I said, it is packed, it is full, but there's going to be a lot of rich discussion, a lot of rich information, and I hope you'll be able to participate in the Q&A section with your questions. Because we are in a webinar format, I ask that you type in any questions that you have in the Q&A section. The chat section is only for technical difficulty questions with Zoom. Next slide, please. Chris mentioned our generous sponsors. First, I need to acknowledge the support of the California Healthcare Foundation. It's been multi-year support for the coalition, so we thank them for their continued support in this work. We also want to thank Buchalter, AARP California, Hims and Hers, West Health, HealthNet, and Alliance for Patient Access. Thank you for your generous support of today's meeting. A few more housekeeping things. This meeting is being recorded. It will be posted within a couple of days on the coalition webpage on the CCHP website. I would also like to thank the hard work of the people who have helped put this together today. Blue Path Health, Golden State Health Policy, and also CCHP staff, Aria Javidan and Veronica Collins. Additionally, you will notice that our committee chairs may be wearing leis today. This is to honor the work that they have done over the year for the coalition. Additionally, it is a small tribute to Mario Gutierrez, former executive director of the Center for Connected Health Policy, who passed away a little over 3 years ago. Mario was one of the founding members of the coalition back in 2011 when we were looking through the passage of AB 415 and started this group with various organizations throughout California that include the California Medical Association, California Hospital Association, California Primary Care Association, the Children's Partnership, and the California Rural Health Association. Mario will be very pleased today to see how the coalition has grown and the important work that it continues to do. So without further ado, we'll go to our next slide. And I would like to introduce Nikki Pascal from Pascal Roth.
Good morning. Hi. I wanted to let you all know about some of the great communications resources developed by the coalition. Some of the ways we are working to amplify the work of coalition partners from a communications perspective, and some of the ways you can easily stay connected to what's happening with the coalition. First, the coalition is now on Twitter, so if you are tweeting today, please take a moment now to follow us at CA_telehealth. Again, that's CA_telehealth. And our hashtag for today is #AccessTelehealth. We'd love to hear your takeaways from today's conversation, and this will be a place where we can share the work coalition partners are doing. So we hope it'll be a great resource and a place to share information and a place where we can all amplify what each other are doing and really get that in front of the eyes of policymakers and others in the community. Second, over the last year, the coalition has developed some incredible, really easy to use fact sheets and materials. And if you're not already using them, I'd really encourage you to check them out. The Debunking Myths sheet is really one of the latest and really great. It addresses some of the common misperceptions about telehealth from really kind of a lay person or common person perspective. So that's really a great one. And also really exciting, we've translated the What is Telehealth fact sheet into Spanish. So that'll be a great resource as well. And those can all be found on the coalition website at cchpca.org under the coalition tab. And I'll put that link in the chat. So just a moment. Lastly, I want to invite your organizations to be a part of our communications conversation for 2021. We'll be convening communications contacts in December following the conversation today about priorities and goals for 2021 to outline the key messages and opportunities that can help the coalition be successful in reaching those goals. So look out for an invitation from Robbie with more details on that. And if you haven't already identified a communications contact from your organization to be a part of that conversation, I'm going to put a Google link in the chat, and that'll be the way to get your communications contact, if it's not yourself, connected to that conversation. So thank you again for your time. Look out in the chat box for those resources, and please enjoy today's conversation. And with that, I'll pass it back to May.
Thank you, Nikki, and I can't stress how important communication is. So I really encourage you to reach out to Nikki and utilize the tools that she has prepared for us. So we will be checking to see, is Rene on yet? Our next speaker will be Rene Malo from the Department of Healthcare Services. We're just checking to see if Rene has managed to log on yet.
He's just getting on now, May.
All right, then. Thank you. So I've known Rene for quite a while. So she is very familiar with telehealth in California and the telehealth policy. She's been very instrumental in doing some of the work around the updates for the Medi-Cal policy. So we are very lucky to have Rene able to speak to us today, because right now around this time of year, they're extremely busy over at that department. And for those, Nikki just posted the fact sheets and some of the communications contact form in the chat if you are interested in that. I really, again, encourage you to reach out to Nikki and also to utilize some of those resources that she is providing. And also, Rene might be able to take one or two questions. So for those who may have questions for her, I would suggest that you start thinking about them, and remember to type them into the Q&A function, not the chat function. The chat is for information for links, and if you're having technical difficulties with Zoom, the Q&A section is where you will put in your questions for speakers. Again, this is being recorded, and you can always, if you need to step away, it will be recorded, and you can always check later if you missed something. But the Q&A function is where we'll be able to see questions and also download them later after the webinar has ended.
Thanks for your patience, May. We're still trying to get her on as a panelist.
All right, then. So in the meantime, a couple other things. I know we have a lot of new people who are not familiar with the coalition, a bit of background of the coalition that, oh, and she is coming on. You can read about the background of the coalition on the CCHP webpage. Hi, Rene.
Hello, May. Thank you so much. And my sincerest apologies this morning for my login difficulty. So thank you so much. I'm very happy to be here this morning.
No problem. Let me turn it over to you.
Oh, thank you so much. So hello, and thank you for the opportunity to discuss our work today relative to telehealth. As you may know, our telehealth policy prior to the public health emergency was very expansive with few limitations. DHCS had undertook an extensive review process back in 2019, which involved extensive stakeholder engagement and helped us to refine our policies around telehealth to afford substantial flexibility to enroll licensed clinical providers. And this allowed them to make individualized and clinically appropriate decisions regarding the use of telehealth modalities for individual patients versus DHCS being prescriptive in terms of identifying specific procedures that could be billed for purposes of rendering care via applicable telehealth modalities. These policies also help to support beneficiary choice in terms of receiving available healthcare services either via telehealth modality or through face-to-face interaction that had been the norm in our program. In terms of our telehealth policy, it was applied across the respective delivery systems, both in terms of our fee-for-service and managed care delivery systems. That revised policy was published in our Medi-Cal provider manuals, and it was also disseminated to our managed care plans via all plan letter. The policy, as I had indicated, focused on providers identifying via modifiers if the service was provided via a telehealth modality, either if it were synchronous or asynchronous. And while we undertook this extensive process and made these major changes in our program, we don't believe that providers were really taking advantage of the policies prior to PHE. So now fast forward to the public health emergency. And because of the implications in terms of the need to do social distancing, providers were thrust into having to leverage our existing policies, as well as the flexibilities that we were able to offer based upon guidance from the federal government. We have provided extensive guidance in this space, and we have also leveraged available federal flexibilities in terms of the provision of telehealth modalities across all of our delivery systems. This has included our ability to pay for telephonic services in the same manner as we have paid for face-to-face visits. And this was a huge relief for our provider community in terms of having this option available to them. We also had the ability to waive site limitations, meaning we had the ability that depending upon where the provider was located or where the beneficiary was located, there were no limitations in terms of the capability of providers to still render services via applicable telehealth modalities. It also allowed us to use billing codes that were typically used for established patients to also use that for new patients. We also allow for certain services to be delivered via telephone only with certain limitations, and then also allow for some specialty areas, such as with our 1915C Home and Community Services waivers, our drug Medi-Cal organized delivery health systems, specialty mental health, drug Medi-Cal program, and our targeted case management and our local educational agencies to also expand services that they provide, and to provide those services using other virtual and or telephonic communications. This also allowed for clinic providers to receive payments for services via telephone at their full reimbursement rates that are used in paying for clinic services, or in certain circumstances, they could receive a reduced payment based upon the Medi-Cal rate on file that was subject to certain parameters. This allowed for payment parity, regardless of the services being provided either by phone or in person, if certain requirements were met. And again, those services had to ensure that in-person visit requirements were met, that those services were clinically appropriate to be provided via the applicable telehealth modality, and that it had to meet all procedural and technical components of the service being provided. We have really appreciated the flexibilities that were afforded to us by the federal government in terms of the delivery of care to our beneficiaries that we serve under the Medi-Cal program. And this was really important given the time, given the environment that we are all working under in terms of the public health emergency and the needs for social distancing. We are now in the process here at the department of evaluating the flexibilities that we were afforded during the public health emergency and thinking through what will be continued post-public health emergency. And I know that there's been a lot of interest in this space in terms of that work, but that work is currently underway within the department. That work includes assessing if there are any needed federal approvals based upon the flexibilities, because there were certain flexibilities that we had to seek federal authority for through what we call a disaster state plan amendment. We're also working through if there are any federal barriers that we need to address. In particular, the one area that we're trying to work through is looking at the provision of telephone or audio services and any implications that may have based upon requirements from the Federal Office of Civil Rights and the protection of privacy of individuals. And so those are areas that are under consideration as we're looking at the provision of additional flexibilities with our telehealth policy post the public health emergency. We're also looking at the actual utilization of telehealth modalities writ large in our program. While we do not have information today to share in terms of what that utilization has looked like, we are internally evaluating this, and this information as well will be used to help inform our future policy in this space. We do recognize the value of the flexibilities that were afforded to the state during the public health emergency, which we're still under. And we also know that prior to the public health emergency, we did have a very expansive program as it relates to the provision of telehealth services. So we want to ensure that as we look future forward, the modalities offered help to ensure the provision of quality services while maintaining program integrity. And foremost with all of this in terms of looking at our policies is ensuring that we are protecting patient choice and ensuring appropriate access to care. And then also looking at if there's any areas where there were inequities in terms of how services are provided or made available to our beneficiaries. Anecdotally, we have heard very positive feedback regarding the flexibilities that we have employed during the public health emergency, including hearing from providers about the ability to continue providing care in a safe and appropriate manner, which was much needed given that absent these flexibilities, it had significant impacts on their revenue without the provision of these different modalities. And so because of the payment policies that have been employed during the public health emergency, it has helped them to maintain services, in particular paying for telephonic services in a similar manner in terms of how we would pay for face-to-face visits when certain criteria was met as previously stated. We have also heard from providers about the ability, because of the flexibilities, continuing to provide much needed mental health services during a critical time of increased need given social isolation in a way that helps to maintain and protect patient privacy. One of the concerns that we have heard is that while we have had these flexibilities afforded to us, there's also concerns about the privacy and how well people can fully engage with their providers during this time period when people are socially isolated or when people are having to maintain that social distancing and being in a home where there may be multiple people around that historically would not have been, an issue if you were going into the office to have those mental health services being provided. We have also heard some feedback from the perspective of our beneficiaries in terms of the ability of families who must juggle multiple appointments for children, say, with special health care needs, and it has increased their ability to access those specialty providers while mitigating the need for transportation to and from providers who may be also located several hours away. But they also felt like they did have the ability to balance out the use of the telehealth visit with also some face-to-face interactions. And for that, they had significantly expressed their gratitude in that space. On the flip side, though, we have also heard of concerns that there may be limitations in terms of the availability of certain types of telehealth services, because in some areas of the state, in particular our rural areas, there's also concerns about the availability to either broadband or internet access, and that some populations may be more impacted than others by this lack of internet access. So the only option that they may have available to them may be through phone calls. Also, the concerns, as I had previously mentioned, about the lack of privacy when provided much needed mental health services. And then also concerns around the lack of secure interfaces for those with limited internet access. And then patients, fully understanding their rights in this space. Because first and foremost, we want to make sure that individuals are fully informed of and know what their rights are as it relates to the provision of healthcare services via telehealth modalities. All of this information is critically important to us and will be taken into consideration as we move to develop our policies post the public health emergency, and then to balance what policies we will maintain versus not. Our ultimate goal in terms of looking at the future for our telehealth policies is a balance of protecting the needs of our beneficiaries while helping to ensure access to quality healthcare services and minimizing any disparities or inequities in access to services via appropriate telehealth modalities. Again, I thank you all for the opportunity this morning to come and share our efforts, and I welcome any questions at this time. Thank you so much.
Thank you, Rene. Well, you do have a couple of questions here queued up for you. So the first one is, let's see. When does DHCS intend to release its post-PHE proposal? Will there be a stakeholder process and a comment period?
So we have not yet had a decision on that timing. I know that that's been a strong interest of individuals. As we have done in the past with our policies, we do look for engagement with stakeholders, but I do not have timing on that at this point in time.
Okay. Our next question is, I understand that DHCS is going to undertake a comprehensive review of telehealth policies.
Mm-hmm.
Prior to COVID, DHCS has imposed restrictive policies keeping FQHCs from being able to establish patients using telehealth. Have there been any problems with FQHCs establishing patients using telehealth under current flexibilities? Any reason other than the current flexibility in this area should not continue?
So we have, as I had stated earlier, part of our process in terms of determining what we're going to continue post-public health emergency is just evaluating the utilization of these services during the public health emergency. While we have not heard of any issues, we just want to make sure that our policies do balance with the needs of our beneficiaries in this space. And so our goal, like I had indicated before, is looking at ways in which we can help to ensure access to these needed services, and then thinking through what types of, if there's any federal issues in terms of that establishment. But we do recognize the value that the ability to establish patients via telehealth modalities, what that has added. So we are taking all of that under consideration as we're looking future forward in terms of our policies post the public health emergency.
Okay. Our next question is from Greg Bucher. DMHC recognizes telehealth services as meeting access and availability standards. Will DHCS also consider telehealth services meeting a health plan's access and availability standards?
That will be an area that we are looking to further explore.
Mm-hmm. All right. From Mike Curlin. Thank you, Rene. Can you talk about what type of information healthcare organizations and other nonprofits can provide DHCS that will move the needle for telehealth services? For example, anecdotes and personal stories are very powerful, but is that enough? Is there specific data that you will need?
So the data that we'll be looking at is the data that has been coming in to us from providers identifying the use of the modalities. I think one of the things that was clear to us when we had made the revisions in our policy is prior to that, our policies may not have been as clear in terms of what was available under the Medi-Cal program. But it's also making sure that providers are equally identifying that these services were made via a telehealth modality. So we believe with the changes that we have made in our program and trying to streamline the documentation, so it's really indicating to us when claims are coming in, was the service rendered via telehealth modality or not? That helps to give us the needed information in terms of looking at the utilization of services. It does help to also hear from our provider community. So when we're at a point in time when, our policies are released and we're having that stakeholder engagement, we can also use additional information. But that's something right now that we're currently exploring in our program, just in terms of looking at our own utilization of services across the various program areas. So we're looking at it both from the fee-for-service delivery system as well as in our managed care delivery system. It's just really critical in terms of that documentation from our providers to know that they are actually rendering the services via the telehealth modality. That will help to further inform our policies in this space.
Mm-hmm. I don't know if you'll be able to answer this, but a question is, does the changing, and I think it's the federal administration, have any impact on the work that you and your team are doing?
That I cannot answer that. I can just say that from our perspective, we're going to continue to do our due diligence in this space, and then we'll look forward to working with the new administration and those individuals at CMS that help to support us in the policies that we make under our Medicaid program.
Okay. And here's a question from Joe. Do the telehealth rules, do they apply, are they the same for Indian health community clinics?
There are some different rules that apply for Indian health clinics. Those policies are set at the federal level by Indian Health Services. But again, we will be looking to see where our policies can align with what is available at the federal level. And then to the extent that we're looking to advance something that may not be readily apparent within those rules at the federal level, then we'll be seeking technical assistance from our federal partners in terms of what our available options are.
Okay. Do you have any comments that you might want to make on Medicaid managed care and parity of coverage of service and payments for that, for telehealth services?
So our policies today would, we would look for our policies to be consistently applied across our two delivery systems, but do recognize that with our managed care plans, they do have contractual arrangements with their provider networks. But to the extent that we have policies that are established that do allow for the payment, say, of a telephone service that meets the face-to-face requirements, and then we pay the same, we would then expect that our managed care plans would effectuate similar policies.
Okay. And we have time for one more question. It's from Fabiola. What is the work that DHCS is doing to ensure that Medicaid beneficiaries have access to broadband as well as access to devices and digital literacy? How are we planning to guarantee current managed care protections with telehealth use? What data are you receiving about patients' experiences that are not coming from providers?
So very good question. And I probably don't have all the answers that Fabiola is looking for. One of the things we have to consider is in our policies today and in what we offer for our Medicaid beneficiaries, we do not offer the actual modality that they may use. So we don't offer, say, telephones, internet access. So that's not part of what we make available. And so that is something we'll have to think through, because those are some of the issues that we have heard in terms of the availability or access to these services. So I think that would likely be a space where we would want to have some additional engagement to think about with, external parties in terms of what may be available.
I'm just wondering if you had a chance to post the
Sorry, just a little bit. So go ahead, Rene.
Yeah, no, so I was just saying is just kind of thinking through what are the opportunities there for individuals that may not have access to those supports in order to help them with accessing telehealth services. So I think that would be an ongoing conversation for us to have, with interested stakeholders in this space. But then also working with our managed care partners in terms of how they are working to then support individuals that may not have access. Again, one of the areas that had been widely used and looked at as an alternative was the use of the telephone, and then how that might play in terms of, our post PHE policies in the telehealth space.
Well, thank you. We're at time right now. Rene, thank you again for taking time out of your busy schedule. I know it must be still extremely busy over at DHCS. So we thank you for coming to speak to us today and for that great presentation.
Thank you so much, and enjoy the rest of the conference, everyone. Thank you again for the opportunity.
Thank you, Rene. Have a great day.
Thank you.
Right now, I would like to turn it over to our committee chairs, Julie Bates and Erin Kelly.
Great. I cannot turn on my video. Oh, here we go.
Well, the first thing before Erin starts talking that I'll share with the whole group is, and we've looked at these slides 52 times, Erin is actually the chair of the Coalition Legislative Committee and has done a phenomenal job in this role. And you're going to hear about all of the work that committee has done over this past year. It is amazing. And I am the chair, or the outgoing chair, of the Coalition Education and Regulation Committee. So other than that, everything is correct on the slide that you see in front of us. Yeah. I'll turn it over to you, Erin.
Can everyone hear me?
Yes.
All right, great. Well, first off, I want to thank the team for my beautiful lei. It is very aromatic. Reminds me of many good memories of Hawaii with my family. So thank you. I also want to express my appreciation for Rene Malo's attendance, her presentation, and the subsequent Q&A dialogue with members. It was very helpful in clarifying DHCS's current evaluative process and the outstanding concerns and challenges that they have. As 2020 is coming to a close, I think we are all probably doing a lot of reflecting about this unprecedented and challenging year. This year feels like a decade in terms of the uncertainty we've had to grapple with, the disruption in our lives, and at times what feels like chaos. As we gathered together at last year's November convening, never could we have imagined what would be in store this coming year and how it would alter and change our lives on both a personal and professional level. For me, I've tried to keep a positive mindset, definitely challenging at times, particularly when I became the primary teacher for my children for a few months. I'm sure many can relate. But I've tried to always reflect and think about the silver linings from this experience. I think we can do the same for our work as the California Telehealth Policy Coalition. Because of COVID-19, telehealth was launched to the forefront of healthcare delivery and led to an unprecedented acceleration of its use. It was a silver lining for all of us that had been working for years to prove its value and advance its use, both in policy and practice. In March and April, nearly every provider was using telehealth in some form or fashion. National data has showed that telehealth use during that time increased by over 2,000%. The work we had done as a coalition over the last 2 years to formalize processes, focus our mission and priorities, and deepen and increase organizational engagement prepared us to meet this moment. I want to highlight some of the coalition's most notable activities and achievements. We stood up what we coined the war room this spring, which included broad representation from all sectors of the healthcare delivery system. These weekly meetings allowed us to flag issues, share intel, problem solve, and escalate as necessary, which led to tangible outcomes in terms of regulatory changes. We increased the number of organizations that participate in our work exponentially, which is now well over 100 organizations, 350 attendees who registered to participate in today's convening. We have effectively solidified the coalition's role as a go-to resource
think tank and policy advisor on telehealth. We hosted a number of high-quality educational webinars, an engaging legislative briefing, and hosted relevant policy and research experts to speak at our member monthly meetings. The caliber of our speakers at these events, included the ones here today, have been outstanding. Most importantly, we have laid the groundwork to work collaboratively on a comprehensive legislative package to codify many of the temporary flexibilities that are currently approved under the public health emergency waivers, as well as other important policy priorities to address barriers and expand telehealth use. I am extraordinarily proud of the Coalition's activities and achievements this year. We could not have done it without the steadfast commitment and passion of its members and the amazing leadership and support of CCHP and Blue Path. I wanted to thank the members of the Legislative Committee for their strategic advisement and engagement. I have mixed feelings about transitioning off as chair. I have learned so much from working alongside a dynamic leadership team and really being at the forefront of historic change in telehealth use and acceptance. However, I am energized about our incoming leadership and the opportunities before us next legislative session for bold action in advancing our policy agenda to realize telehealth's fullest potential. Amy Durbin with the California Medical Association was going to be our next fearless chair leader, but unfortunately she can no longer serve at this time. However, we owe her a debt of gratitude for her expertise and commitment to this work. She has been instrumental in our successes over the years, and I know she will continue to play a meaningful role in this space. I'm pleased to announce that Lisa Matsubura will be stepping in as the chair of the Legislative Committee. A skilled advocate and political strategist, she is well seasoned for this role, and Planned Parenthood has been a key partner in our legislative efforts. Congratulations, Lisa. Now I'd like to turn it over to our education co-chair, Ms. Julie Bates. She has been a true blessing to the Coalition, a real change agent and champion for telehealth and health equity. Her passion for these causes are infectious. Just hearing her speak always lifts me with hope and optimism. Julie, it has been a pleasure serving with you, and I want to commend you and the rest of the committee for your collective efforts to thoughtfully design and produce meaningful educational materials and opportunities to expand knowledge of and awareness of telehealth and its many benefits. Thank you for your service.
Oh, Erin, thank you so very much for those kind words. It has truly been a pleasure and an honor to serve with you as part of the leadership of the California Telehealth Policy Coalition. You know, I tell this story every year when they said to me at AARP, we want you to lead the work in regards to telehealth for the state. Many moons ago, my first response was to go, why? And to have a whine moment. But I have truly become a telehealth evangelist, for lack of a better word. I have been able to see its impact in people's lives, including my own, when my family had need to access telehealth services in order to access specialists for care. I've been able to see its impact for elders across the spectrum, from low-income elders to elders who are aging well. Telehealth is the future, and I'm really pleased that I could have played a role in moving this important modality forward. You know, the unintended beneficial consequence of COVID-19 is the barriers that have been put in place year after year after year as to why we couldn't bring telehealth to the masses were literally blown up. You know, for years before, we were told, well, we can't have broadband expansion. It's too expensive. We can't do it. Oh, no, can't, no will, can't possibly. And now we recognize, because of COVID-19, you can't go to school, you can't go to work, and you can't access health care without it. And because of the work that we have done over the last many years, including this year, we were ready. We were ready to say, this is what can be done, this is what should be done, and we helped people turn the corner from traditional medical delivery in the clinic setting to utilizing telehealth across modalities, from big clinics to small clinics to doctors' offices who had never thought of using telehealth before, to jumping in with both feet. But the coalition and the education subcommittee did a lot of really important work that we were poised to do because of the foundation of what we've had. As I said before, it has been a phenomenal year for member engagement and outreach as the unintended beneficial consequence of COVID-19. We have built our organizational base up to 133 organizations and growing, and these members include healthcare organizations, payers, consumer groups, clinics, hospitals, colleges and universities, organizations reaching children and seniors, and provider constituencies. This is huge. We do better work when there are more of us at the table. We did great work before, and we really thought about great things, but you can't think of everything, right? We all know what we know, and we don't know what we don't know. And when we bring diverse voices to the table, we know more, and we know more questions to ask, and we're able to do more. This year, we provided 3 quarterly newsletters that really helped our constituencies understand what was going on. It was a shocking and surprising time on March 13th when the entire state shut down and we all went home to work. And those that couldn't go home to work had to figure out how to work in the COVID-19 environment. And with the War Room and the publication of newsletters, the members of the coalition were better armed to provide services for the people that they serve. And then one of the things we've talked about already is in regards to our stakeholder fact sheets. Nikki talked about it at the beginning. We've mentioned it throughout. These fact sheets are awesome. They have been instrumental in helping us to understand what health delivery is in the post-COVID-19 world. It helped the legislature to understand. It helped health clinics. It helped us all. And we were able to even provide fact sheets in Spanish. We would love to be able to provide fact sheets in all of the languages that are represented in our state, but we didn't have the resources. But hopefully, maybe one of the 144 plus people on the phones today organization would like to partner with us in 2021 to help in translating these fact sheets into more, so that more people can understand in languages that are important to them. And then, of course, the next thing is in regards to our webinars and our briefings. We talked about the War Room, and at the first meeting of the War Room that had more than, I think, 75 organizations that were really new to us, right? People who had not been engaged with the coalition before. They talked about they needed information and they needed it now. And so we turned on a dime. We had not been known for webinars before. We had done wonderful in-person events like this one. We had done our in-person legislative briefing, but we knew that the webinar format was important. And so we literally turned on a dime and started producing these webinars, including everything from how do I do a visit if you're an older adult? What do I do? How do I do it? What does it look like? What's different? What's the same? To helping our clinics understand the new expanded benefit and how to bill for it. And we both talked about the policy briefing. The policy briefing really helped we had hoped that when we did the policy briefing that we would be talking about all of the successes that we had in making the temporary expansions permanent. But we're able to pivot and talk about what do we need to do in order to make these expansions permanent moving forward. And that did take place. So, it's every year I think we've done bigger and better than the year before, but 2020 really is an example of how we really did accomplish this goal. You know, I have had the great good fortune to be the chair of the Education and Regulation Subcommittee for sometimes feeling 5 years and sometimes feeling just a moment and a half. And I have learned, as Erin mentioned, so much more than I ever would have been able to learn had I not been in that position. I am grateful to May and Robbie and the team that helped me have productive meetings. I am grateful to my committee because the committee really helped to make our thoughts into reality. And as I leave the chair role, I have absolutely no concerns because Dr. Anthony Magid is going to be taking on the mantle as chair of the Education and Regulation Subcommittee. And as his support in the vice chair position is Joe Garbanzo's executive council member for volunteer for AARP. So I know that this committee is going to continue to do great things in 2021. And I ask you to be involved. You know, we all like to come to this meeting and to hear what has happened and to learn what has happened and to be able to gain insights to do even better work moving forward in the years to come. But we truly cannot do this alone. And we welcome your active participation, whether it be in the Education and Regulation Subcommittee or the Legislative Subcommittee or even the broadband work group. These all are made better by your active participation. Again, I'm so very thankful for having had the opportunity to lead this subcommittee. It was an honor and a privilege. It's always an honor and a privilege to be with you at these meetings, and you'll never get rid of me. I will continue because, again, as I said at the beginning, I have become a telehealth evangelist. I see it as the future. I know the power of its use, and I can't wait to see what we do with it.